heard some of my in my other talks, I don't. To me, it's a little bit more detailed and a little bit more cumbersome than some of the other talks that I've done. But I'm gonna pull everything together at the end and really try to simplify things. Once we get to the point where I'm starting to simplify and try to make things easier, I'll let you know. So I just want everybody to know is that I have some CTSC funding, and I've had some costs covered by the Canadian government, as well as and what's not on here is a little bit from the federal government of the U.S. as well. Um, and then I've got with the New Mexico Bridge program, I've got some funding from that as well. I don't have any other conflicts of interest. Any trade names that I talk about are not in specific relation to I'm because I'm recommending one particular treatment or another. Sometimes I accidentally slip and say the trade name as opposed to the generic name. Yeah. Okay. So we're going to discuss some common testing that's used in drug testing methodology. One of the things that I'm consulted on or asked to be involved on multiple times a week has to do with false positives, false negatives of drug screening and how to make sure we get those testing results if we need to get them accurate for like a court of law level. And so we'll talk about two primary ways of testing. We're going to talk about some of the pharmacology of buprenorphine, specifically the pharmacokinetics. I know before I did talks, anytime somebody said the word kinetic, I started Pavlovian response of just falling asleep. So that's kind of my way of getting around it. And then we're going to talk about genetic testing too, associated with buprenorphine. So I think one to understand the difference between having a drug screen and a drug confirmation. So a screen uses an immunoassay, i.e. dollar store technology, and is usually limited to the urine. Advantages that it's quick and easy. It's inexpensive. Like I said, this is dollar store technology. It's widely available. You can do this in your own office. There's it's CLIA exempt. So CLIA is like the Joint Commission, but oversees the labs. But the disadvantage is there's a lot of false positives and false negatives. So confirmation testing involves chromatography tandem to a mass spectroscopy. So going back, if chemistry is a repressed memory, another way to describe what chromatography is it's like distilling alcohol to make moonshine. So you heat up the substance, which is a heterogeneous mix of compounds of water, ethanol, a bunch of other stuff, and then based on that temperature at a given time, and then that there's the metal column is that change in the heat separates out the different compounds over a period of time. And so we're able to get an identification of the compound based on that. The two major forms of chromatography that are used right now is gas chromatography, but that's being replaced here, especially over the last decade, with liquid chromatography. If there's questions at the end, I'm happy to delve into differences of the two if the audience is interested. Otherwise, I'm just going to keep going. And then mass spec essentially takes the molecule that's come off the column, bombards it with electrons, and essentially makes the molecule fragment or shatter, and then is able to measure the mass of all the different fragments of the molecule. And so coupled together, each compound has a unique, essentially fingerprint that's very specific to it. We can use blood or urine or any other body fluid to do confirmation testing. And I think, and the ability to detect on blood has some potential advantages on therapeutic monitoring to understand what the CNS is. We're talking about drugs of abuse, but what the CNS with opioids is actually seeing. Whereas urine, we know the first void of the day after you wake up is usually the most concentrated, and then it gets more dilute as the day goes on. We can also, yeah. So when you do drug monitoring, whether it's uh, lithium, alcohol, phenytoin, valproic acid, acetaminophen, salicylates, theophylline, caffeine. All those are done on blood or plasma as opposed to urine because of accuracy. There are a couple of exceptions of lab monitoring where we use urine, namely the heavy metals and tox testing, but that's beyond the scope of this talk. So the advantages are that it's highly sensitive, highly specific. So it's far more sensitive, far more specific um, than the urine drug screen. Also have the capacity to test for a whole bunch of different compounds. So one of the things that oftentimes creates a little bit of confusion is methamphetamine and amphetamine are slightly different different compounds with a methyl group that's different. In GCMS or LCMS, I have the ability to differentiate methamphetamine from amphetamine and to have quantitative values for both. It's a little bit more expensive to obtain, and really you need a PhD spectroscopist is usually who's overseeing the lab. Because of that, there's a limited number of labs. So the one lab in that does biological samples in New Mexico is Tricor. Quest, for my colleagues out in Roswell, who I believe Roswell uses, they have the capacity to do this as well. The state lab does, but again, and so do the national labs, but those are usually not readily available to practitioners. So I kind of alluded to this a little bit earlier, advantages of blood or urine as testing. So on blood is the clinical concentration, we can make clinical correlations with it. Disadvantages is we may miss recent use. So the example is so somebody that we're monitoring for alcohol use disorder, and we draw a blood alcohol level now when they showed up in the morning. They may have cleared their alcohol from the night before, and we would have missed that. And it's a little bit more complex, but when you're getting into the LCMS, GCMS, the complexity, it can be done, but then I'm starting to look to go with a national lab, as that's a little bit beyond what Tricor does. And to my colleagues in Roswell or those who use Quest, I'm not quite sure what their capacity is to do blood samples on LCMS, but if you have any comments, feel free to share them. Urine has the advantage of being really quick and easy. I mean, you just come in and you drop the urine sample. We're also more likely to detect recent use. So again, we talk about the person who drank some alcohol last night, and our ability to detect one of the metabolites of alcohol in the urine will allow us to turn the clock back a little bit further. In the addiction clinic, I think this is a real value as we're trying to monitor for compliance. The urine concentration, while Tricor does report it and other labs do, I think it's really hard to interpret what that means clinically with the patient. I just look at it more as it's either present or not present. And then things when I'm looking for like methamphetamine or buprenorphine, I'm also looking at what are we seeing for metabolites, and are they present? So I think the indications for drug monitoring, there's several papers that have looked at this, and of all places, I found this out of the Korean Journal of Internal Medicine to be helpful. Is that monitoring really should be done on drugs that have a narrow therapeutic range, something like warfarin, digoxin, drugs that have marked pharmacokinetic variability. We'll talk about some of the variability in relation to buprenorphine as we go, but I think of like lithium as a prototypic example of this, to phenobarbital and phenytoin also, as they are inducers and inhibitors of other drug metabolisms. Also, drug medications for which the target concentration is difficult to monitor. Um, so again, this falls into some of the therapeutics or chemotherapeutics, where if we don't want to put the patient into like methotrexate, for example, we don't want to cause a multi-system organ failure, but we can't readily tell where the patient's necessarily dosed with it. And then drugs that cause therapeutic or adverse effects. I think this is kind of a little bit of a broad area, but we're checking here. And I would suggest adding in within the addiction realm, a little bit on verifying compliance. So going with the pharmacology, this is from the PCSS course. As a reminder, buprenorphine is a partial agonist, meaning that we get a plateauing of our respiratory depression. So about at the 16 milligrams, so the 32 and the 64 milligrams, where while I understand insurance doesn't cover these higher doses, in clinical studies, it doesn't appear that those higher doses of double or quadruple the value results in any more respiratory depression. So I think there's no reason to give buprenorphine monitoring because of its narrow therapeutic index. We also get the partial agonism of buprenorphine, as a reminder, may have some benefit in people who relapse or are still heroin or fentanyl that they've obtained from the street. So whenever a toxicologist gives a talk on one specific drug, you feel rest assured that you're going to see the chemical structure of it. So I don't want to scare you, but I'm also a visual learner. And my intent isn't for you to memorize the structure. I can just draw by the names, but I'm a visual learner. So we have bupropion over here, 3 different methods of hydroxylation, dealkalinization, or hydroxylation, and to give us some different components and different metabolites. What's important is going to be the CYP enzymes that are involved here. So as a reminder, in medical school and pharmacology, we learn about the P450 system, and as a whole. More specifically, we can break or subdivide the P450 system down into subgroups of CYP enzymes. The most common ones that are used to metabolize buprenorphine are 3A4 is the primary one, and are shown here. 3A4, as you may remember, for those of you who took the time to remember your CYP, is the primary enzyme that metabolizes the vast majority of our drugs. Most opiates like hydrocodone, oxycodone, use CYP2D6, which is a different enzyme than what is used by buprenorphine. I should also note that if I don't have the slide, methadone is also metabolized primarily by 3A4 as well. So there are several drug interactions here. I think if you can memorize this, tell me how, because every time I look at this, I think I remind myself of different ways that I'm thinking of. We talked about the barbs being an inducer, carbamazepine, oxcarbazepine. I know both myself, Snehal, I think, Dan Duhigg is with Press, but I know we're using more and more carbamazepine, oxcarbazepine to treat acute alcohol withdrawal in the outpatient setting. Some of your antiretroviral drugs do, phenytoin. And then, yeah. So, it's one where it's not quite to the point where with buprenorphine that I run a drug checklist on every time, but I just kind of pay attention to some of the bigger ones here. We have, remember, 2C8 interactions. Gemfibrozil is an inhibitor and rifampin is an inducer. And I think those are going to be the two most significant. Clopidogrel is a bit of an inhibitor, but I think it's to a little bit of a lesser degree than gemfibrozil. If as far as getting target concentrations go, these appear to be buprenorphine target concentrations at different doses in a small tested population. And these are done on blood, not urine samples for your reference. So as far as genetic testing, I know when I did my med tox fellowship, I thought we would see a lot on genetic testing and drug metabolism, and we would be really leaning on the pharmacists and others to give some different dosing guidelines based on the amount of genetic activity. Fortunately or unfortunately, depending on how you look, that hasn't really panned out. There are some genetic variations in 3A4 and 3A5. Women tend to have higher activity than men, and pregnancy can also induce 3A4, 3A5 activity. Some of the data is limited, but if you have somebody who's an ultra rapid metabolizer or a very rapid 3A4 metabolism, they may need a higher dose of buprenorphine or methadone. They may also need to have some of their doses that are split up more frequently. Insurance is generally not covering the cost of the genetic testing for treatment of substance use disorder. For other conditions like 2D6, and if you're going to need to be on codeine, for example, we need to know what that is helpful to know, because if you have very little 2D6 activity, codeine gets metabolized into norcodeine, which is an inactive metabolite, and you have really no activity. People who are ultra rapid metabolizers can bump their the conversion of codeine to morphine fairly quickly, and can lead to clinical problems, especially in breastfeeding. So if I haven't confused you yet, here's the part of the talk where I'm just going to really look to try to simplify things. So looking at the package insert, which is, as everybody is well aware, is based on the clinical trials, we should be adjusting the dose of buprenorphine based on withdrawal symptoms and cravings. The metabolite range, again, want to be, if we look for the presence of the metabolite indicates that the person has ingested it and the body has metabolized it, i.e. that they're not able to just cut a little corner of the buprenorphine strip off and put into their urine to try to fool the drug screen. The presence of naloxone or naloxone metabolites in the setting of buprenorphine testing would suggest that the patient's been crushing, injecting naloxone, or there's recent naloxone administration. Remember, when used sublingually or orally, naloxone's not absorbed. What is poorly absorbed and really not bioavailable. So my recommendations are that while I'm aware of the potential implications of genetic variation and the testing, I generally I follow the package insert. I make this easy for myself and for the patient. My goal is to treat the patient to have the cravings and the withdrawal symptoms under control. Once I do that, I'm at a right dose. If the patient is drowsy, I'll back down the dose, and we can discuss some of that. And then drug testing for treatment compliance is the direction that I prefer to go. It's just because it's so easy to get in the immunoscreen and a quick dip that day and have the results. My approach is, if it's positive or something unexpected, I have a chat with the patient and I ask, and I let them know what I was seeing. And if the patient says, yeah, I used some, was using some fentanyl this weekend, it was Memorial Day weekend at a party. But I'm going to be honest with you, I'm done with that. I mean, I trust my patient, but if the patient's like, oh no, I definitely didn't use anything over the weekend. I don't know how that got there, but I need to make treatment decisions. That's the type of case that I would move along to confirmation testing, and I would just have an open talk with the patient, and that way we get the good accurate results. It takes a little bit longer, and then usually the patient has some time to think about things too. I have, in my practice, I can't think of a single time where I've gotten see SIP genetic testing in the addiction clinic, and so I would just I wouldn't pursue that at this time. If there's other conditions that insurance and is going to be more of an evidence based, then I would go with that. With that, I tried to finish a little bit early